My name is Femi Duileme. I'm a registered nurse, psych nurse. And my presentation today is something a little bit different from probably what we'll be hearing. I'm going to talk about high suicide among the Inuits of Canada and how I was able to care for some families when I was a community health nurse out there. I presently work in Daran as a senior clinician behavioral health. Suicide has been a big and significant mental health issue in Canada, and most importantly among the Inuit of Canada. The Inuits actually are the indigenous people of Canada, and they live in a territory called Nunavut, which is the newest territory of Canada. They live in isolation and very remote. The population is very small and spread all over the territory. So this terrain actually presents challenge to every type of health care this group of people are getting. Suicide is among the 10 leading causes of death in Canada, but significantly among the Inuit of Canada, the suicide is actually about 11 times higher than the Canadian rate, and probably much more higher when you compare them to the other population of people. And if you look from my presentation, is the prevalence is actually around between young men, among young men of 15 to 24 years of age, and the rate is about 500 per 100,000 people, which is close to 50 times of the national rate for this group. Nunavut itself have no real connection to any part of the world, either to Canada or to other part of North America. So this is another challenge. People live in pockets. The biggest population of a community could be about 5,000, and we have the smallest population of about 180 people. I need to say that a lot of them, because of the small population, they are related to each other. So when suicide happens, it becomes a very difficult thing because so many people are affected because they are all like very small families. In the suicide group, only about 12.5% have taken psychiatric medication in the past and probably have been seen by a mental health worker for like a crisis type of intervention for anxiety, anger management, and stuff like that. Research shows that most of the people have never taken medication. I mean, most of the people who committed suicide have never taken medication. Only about 17% of them have been hospitalized for mental health problems. I would like to say that all my years of working with this group of people, none of my regular patients that are under mental health care committed suicide. Rather, these are regular people on the street, regular working class people who kind of commit suicide most of the time. There's some historical phenomenon into this. In those days, we do understand that the elderly Inuit will voluntarily abandon their lives to the elements. The elements, I mean the elements of the weather and so on, so that they are not actually become burden to the relatives. One cultural thing about the indigenous Inuit is that they move from one place to the other. They are a little bit nomadic in those days before the government of Canada started resettling them in different communities. So in those days when the weather is bad and an elderly person or they have a sick person among the group, they will just leave that person behind to die. They will not carry them. There's some social explanation too. People say maybe because of the social changes, because of social disruption, the government went in there and disrupted social life of these people. That might be contributing factors to one of the contributing factors to the to high suicide rate among them. And people have mentioned the impact of colonial relationship, but that is just debatable because a lot of African countries and Asian countries were under colonialism, but they did not have such high risk of suicide, or maybe it was not recorded at that time. There's a lot of other contributing factors that have been mentioned, like low self-esteem, interpersonal and social environment stressors. The interpersonal and social environment stressors were found to be unusually extensive, and the primary precipitators of psychiatric crisis in among this group, and that crisis often lead to suicide attempts or suicide completion. There's a negative determinants. As I told you, they live in a very difficult terrain, so they do not get all services that we get in mainland Canada. So and because of that, they have high unemployment, overcrowding. Because of the overcrowding, there's a lot of domestic violence, including sexual abuse, molestation, assault, and all that. And there's a lot of substance abuse, which some people will say is a way of coping with their problems. They talk about intergenerational gap. Trauma and traumatization is a very significant part too. In other parts of the country or somewhere else, when people get traumatized in one part of the town, let's say in the northern part, they were able to relocate to maybe to the south. But because of the way these communities are set up, it's like a bundle. So people cannot really move around. So whoever, let's say for example, somebody has been traumatized, have been raped by somebody, it's most likely you run into this guy or this person once a week in the store. So there's no way to get away from this person. So that as well is a contributing factor. So now talking about working with the family, every type of work in mental health actually have to be holistic and family centered, because most of the time the family are used as the ultimate support system. I will be talking about some considerations here. It's always a very difficult thing to start conversation with a family member when somebody have just committed suicide, because it's not like a natural death. There's a lot of anger, there's a lot of negative emotion around it. People can be very judgmental as well. And as a nurse yourself, you have to be self-aware of your feeling around people who committed suicide and your feeling about around death and dying. And that will help a lot in the way we intervene or try to help the family. As a direct result of increasing number of young people dying by suicide, more people are bereaved. As I said, because of the nature of the population, they're very close and they're small families, they're all related, cousins and cousins. At one time of a suicide incident, you might have at least 6 people that is immediately affected, and that could be up to 30 people or more in the community. I was looking at some therapeutic interventions I did use when I was over there. And the most important part is, one, to establish a positive relationship with the family. The nurse have to present self as non-biased and very sensitive, because they need to build trust in the nurse to be able to do a lot of this bereavement work, because this is an unusual type of bereavement. Yeah, empathy is key, and showing them that you understand what they're going through, expressing to them the fact that you understand their culture and how this affects a lot of people is very key to work with the family. Then this group of people, they're very resilient. So we try to use the strength, identify the strength in the individual or the group or the family to help them go through this difficult time. Um, so we provide different type of assistance and support to the family managing their grief, and this might include using their chiefs, using the elders in the community, coordinating with the church, everybody in the community that could be of help to this family. So we don't basically just focus on the orthodox type of mental health intervention. We have to think outside the box. We encourage the family to communicate their personal feelings, thoughts, and beliefs with other members of the family. They need to be open and talk and talk and talk so that people can let out how they're feeling and all that. And it's good to acknowledge, to acknowledge individual feeling among the members, because different people respond differently to this tragic situation. The main job of a nurse, of a mental health nurse there, is to act as a knowledgeable liaison between the family and other community agencies and to move the family forward. The challenge in this community, as I said, is that this suicide happen so frequently that sometimes it's easy just to forget how it impacts life of people. I was looking up on some intervention of the past. One was a psychological autopsy interview approach by Kizar in 2011. This type of interview allowed the patient or the group of people to reconstruct the circumstances that surrounded the suicide and let them able to talk about it. Eventually, they have like a therapeutic value, and it give them an opportunity to express their plight and derive support. So they will eventually have a compassionate connection with each other, and it promotes a self-understanding. Children is very difficult trying to deal with children who are survivors of parental suicide. We only, most of the time, we encourage them that let the child talk about the death, let the child exaggerate it, let them talk and talk and talk a lot. And the family should be aware that there might be some changes in the child behavior as a result. There could be some regression in behavior. Maybe the child who have been potty trained will now start peeing again, wetting bed at night. And there could be some aggressive and irritable behavior. But all these are normal for a period of time. When we look at medication management, we always prefer not to give benzodiazepines because this numb the grief process. But in a catastrophic situation where we know the person cannot cope, some benzodiazepine short-acting ones like lorazepam have been used in the past. And we find trazodone a little more helpful in low dosage at bedtime. It helps with mood regulation and promotes sleep.